we will be presenting in stillbirth diagnosis, undetected IUGR, and placental insufficiency in stillbirth. So the incidence in the United Kingdom, according to the Office of National Statistic figures, have show a sharpest drop in England to 4.12 per thousand stillbirths, and it represents a 23% reduction compared to the previous 10 years average, and this is representative to 860 fewer stillbirths each year. The proportions that is small for the gestational age has reduced is important, is significantly important, is from 39.4 to 30%, and this is attributed to the use of the growth assessment protocol. Unexplained stillbirth can be reduced by the use of a category of intrauterine growth restriction using charts customized to the mother's parameters and fetal growth measurements. Whatever is less than 10 centile for the gestational age, we can call it intrauterine growth restriction. So in the old Wigglesworth classification, the largest category of stillbirth was unexplained, 65%, and unavoidable. And that precisely goes what Samantha was saying, and everything should be explained, unavoidable is possible. In the UK, we tend to follow the recode classification. Many centers like Sheffield, we follow that because it's an obstetrician and is working with them to try to speak their language. So it's relevant condition at death. And when they developed by Gardozzi and the East Midland teams in 2005, I believe, and they found that 43% of the cases are corresponding to fetal growth restriction, and that is an avoidable category. So they identify fetal growth restriction as the single largest category, 43%, and these findings help to achieve a radical rethink and suggested that many deaths are in fact not unavoidable. And these efforts should be addressed to achieve antenatal recognition. So this is the classification, and I'm going to concentrate in fetal growth restriction and other placental insufficiency. And when the obstetrician says placental insufficiency, because this is an obstetrician classification, it can be that the pathologist found infarction, fetal vascular malperfusion, bilitis of unknown etiology, massive peribilious fibrin deposition, etc. So the risk of stillbirths in pregnancies with IUGR increase regarding to where it was detected. If it was 3.4% is when IUGR was detected antenatally, but increased to 6.5 when IUGR was not detected antenatally. And 32% of the stillbirths could be attributed to this group. A pregnancy with IUGR detected antenatally were delivered on average 10 days earlier than those not detected antenatally. And this means the difference in the outcome of the pregnancy. I have co-authored this book on the pediatric and perinatal autopsy, and then in this we consider that intrauterine growth restriction is an chronic mode of death, and there are placental causes like small placenta, ischemic placenta, bilitis, maternal floor infarction, etc. And we were looking into this when we did this paper recently published, I think last year, about the analysis of unexplained stillbirth. And we came to the conclusion that undetected fetal growth restriction and placental insufficiency were and are the prevalent findings. So we analyzed a cohort of clinically unexplained stillbirths referred to us for postmortems, and to identify if there were recurrent relevant condition at death which could merit interventions to be put in place to reduce the number of stillbirths in the area served by our department. So we define stillbirth for this country. It has to be after 24 weeks completed gestational age. We look back at the postmortem reports and the placental histological findings, the weight, the gestation, the sex. Is very important, the feto-placental ratio, the liver, brain to liver ratio, etc. We excluded many conditions, and at the end, we found that this clinically unexplained 10% of postmortem during this period, and there were 258 clinically unexplained stillbirths. They were more common in males, And it was 51% had one recode, but some had 2 or even 3 recodes. And when you see the distribution, 37.8% corresponded to placental insufficiency and almost 25% corresponded to intrauterine growth restriction. And what is important is that the presence of IUGR was frequently seen together with maternal vascular malperfusion, and in most cases with fetal-placental ratio more than 90 centile had as well placental insufficiency, and this was clinically significantly achieved. 62% of the recodes corresponded to IUGR and maternal vascular malperfusion, and the gestational age had a mean of 34 weeks for IUGR and 35.5 by placental insufficiency. That means that the stagnation, growth stagnations come earlier, preclude the histological features. And you can see that in this chart. So I already say that the most frequent findings, 39% had placental vascular malperfusion or small placenta. This is some of the histology of an infarct, decidual vasculopathy, atherosis. So take-home messages is that all stillbirths should have a postmortem, should be offered a postmortem. The postmortem should include the placenta. Don't forget ancillary studies. Look for a specialist or interested pathologist. Have good communication for us with clinician, for you with us. And that more than 50% have more than one recode, especially placental insufficiency and fetal growth restriction, and that monitoring of fetal growth should be optimized during the 3rd trimester, and intervention measures should be considered in the event of fetal growth stagnation and or reduction.
So that's very well, but that's the placenta after the unfortunate event. So how can we use that information that's really essential that Marta's got and bring that back for future pregnancies and for any pregnancy going through? So the placenta is a very neglected organ, as Harvey mentioned in his introduction, and we need more assessment of it. Currently, the interest is in IUGR and placental vascularity, looking at perfusion and placental oxygenation. There's 2 small groups doing that, one out in Denmark and one in the UK. It's quite technical, it's quite challenging, and I think we can do that and expand that, but there's some very simple things we need to do. So we want to look at the size on ultrasound and MR, the surface area of attachment, not just the size of the overall placenta, but does it look normal? Is it the right shape? What does its volume look like? What does its texture look like? When I see a cross surface area of a placenta on imaging, some of them look like pancakes, some of them look like little cupcakes or muffins, and some of them look like pancakes or crumpets. So they are very different. And there's a few examples on this slide for you. There's an example on the left-hand side of the slide that shows you a very different placenta. It's got lots of abnormal signal in it. That's not a normal placenta, and we need to follow that through. We need Marta to see that and other colleagues to see that at pathology and work out what that's showing us at an early stage in pregnancy. The middle 2 images show you a very thick placenta. That's far too thick. It's got a small surface area of attachment and it's very, very chunky. That's not what I see typically normally. So what does that mean? Its weight and its volume will be okay as a normal placenta, but it's certainly got a very different perfusion, and we can get a lot from just shape. And then the other one's showing you what we can measure and what we normally see in a placenta. So this is some work we've been doing with bioengineering, and they're looking at different placentas and making us computerized models, flattening the placenta out, making it look like what the pathologist will see, but early in pregnancy, and getting us some really good data. So we're going to try and do that and get our normative data out and then try and put pathology into that. There's a series of slides now that just show you different. This is a chunky placenta with a baby. There's one that shows you a very large placenta, and there's one that will show you a normal size placenta, just to give you an idea of what we can do and hopefully how we can bring that back. So this is more extensive placenta. And then the final slide will show you the histograms. This is looking at texture. So this is just computerizing the images we get to find the texture of the placenta. And as you can see, the one on the left is the histogram I'd expect normally. So very narrow intensity and a very tall peak. And then when we get abnormal textures, we're getting this wider histogram. So following these placentas up, hopefully Marta can work out what we're seeing, and then we can work backwards to predict what we're going to see and what will happen to these pregnancies. Next slide, please. So we need to look at the placenta, ultrasound and MRI. We desperately need the normative data. We need to use that for future pregnancies. We need the data in high-risk patients. We need to follow it up with pathology, not just incinerate our placentas. We need to create data for use in all pregnancies that's simple and clinicians can use and not add extra time to their appointments. And then hopefully we can predict possible in the future, or at least additional predictive biomarkers to add in to looking for fetal movements, looking for growth size. So hopefully that gives you an idea of where we're trying to go with the pathology support and bring it into clinical practice. So thank you.